Hello, my name is Alan Bell, and as co-chair of the Hypertension Canada Education Committee, it is my pleasure to thank you and to welcome you to the At-Target program, an assessment of hypertension guidelines adoption in your practice. The At-Target program is based on a premise at Hypertension Canada that the threshold and target blood pressures that we are aiming for are lower in those at greater risk. This is a principle that we have always had in terms of having lower targets for diabetes, but lately we have decided to expand that somewhat to include higher risk patients. And that's based largely on the results of the SPRINT trial. You'll recall that the SPRINT trial looked at patients who were over the age of 50 with systolic blood pressures between 130 and 180 with additional cardiovascular risks. Those included clinical or subclinical cardiovascular disease, chronic kidney disease with an eGFR between 20 and 60, a Framingham risk score for the 10-year cardiovascular risk greater than or equal to 15%, or age greater than 75 years. These patients were randomized not to any specific treatment, but to a blood pressure target, either an intensive target of a goal systolic blood pressure of less than 120 millimeters of mercury, or a standard treatment with a goal systolic blood pressure of less than 140 millimeters of mercury. Patients were excluded from this trial if they had had any history of stroke, diabetes, heart failure with an ejection fraction less than 35%, or heart failure symptoms, proteinuria of greater than a gram a day, or severe CKD with an eGFR of less than 20 milliliters per minute. Excitingly, the SPRINT trial showed that the primary outcome of acute coronary syndrome, stroke, heart failure, cardiovascular death was reduced by 25% relative risk reduction by targeting a systolic blood pressure of less than 120 in these patients. In terms of all-cause mortality, 27% relative risk reduction was achieved. Of course, there were adverse events associated with lowering blood pressure to less than 120 millimeters of mercury. Specifically, there were higher rates of hypotension, syncope, electrolyte disturbances, and even in some cases, acute renal injury. However, it should be noted that one might expect falls to be increased, and they were not in these patients. And in fact, orthostatic hypotension was actually seen to be decreased. Kind of a surprising finding. So as a result of this trial, Hypertension Canada has decided to lower the threshold values for initiation of pharmacologic treatment in patients who fit those SPRINT criteria to a systolic blood pressure of greater than or equal to 130 for initiation of therapy, and as has been previously recommended, the threshold values for other conditions including diabetes, patients at moderate risk, those are patients with hypertension and any other cardiovascular risk factors, or patients at low risk, those with no risk factors, those targets have been unchanged. But what about targets? So if we are going to initiate therapy in patients who fit SPRINT criteria at less than 130 millimeters of mercury, then what target should we be aiming for? Well, like the SPRINT trial, we're going to be aiming in our guidelines to get those patients to achieve a systolic blood pressure of less than 120 millimeters of mercury. And in the other cases of diabetes, these remain unchanged of less than 130 over 80, and all other patients less than 140 over 90, unless an automated office blood pressure is used, in which case we lower those targets by about 5 millimeters of mercury to 135 over 85. I want to also emphasize that in our high-risk SPRINT type patients, we are basing this on automated office blood pressures. If we're going to be using it on standard wall sphygmomanometers, then we really can't apply it, because as we all know that there are differences between the AOBP measured as well as compared to the manual measurement. So the new guideline post-SPRINT is that for high-risk patients aged greater than or equal to 50 years with systolic blood pressure levels exceeding 130 millimeters of mercury, intensive management to a target systolic blood pressure of less than or equal to 120 millimeters of mercury should be considered. Intensive management should be guided by automated office blood pressure readings. And patient selection for intensive management is recommended, and caution should be taken in certain high-risk groups. So specifically, the Sprint criteria do not apply to those with heart failure and ejection fraction less than 35%, the institutionalized elderly individuals. It does not apply to those with diabetes or to prior stroke or to those with an eGFR of less than 20 milliliters per minute. And specifically, it does not apply to those who are unwilling or unable to adhere to multiple medications, because that's what's going to be required to achieve a systolic blood pressure of less than 120. Patients with a standing systolic blood pressure of less than 110 should not be included. Inability to measure systolic blood pressure accurately, obviously, we can't include those patients, nor should we include those with secondary causes of hypertension. As I've mentioned, automated office blood pressure measurement is the preferred method by Hypertension Canada. I'm sure most of you are familiar with the BP True device, which you see on the right side of the diagram here. And if we're going to be following patients at high risk, then this is the method of blood pressure that should be used, as was used in the Sprint trial. Automated office blood pressure measurement, we know, more closely approximates the ambulatory blood pressure than do routine office BP measurements. And furthermore, it is more predictive of end organ damage, such as left ventricular mass index, reflecting left ventricular hypertrophy, proteinuria, and atherosclerosis as manifest by carotid intimal medial thickness. What else is new in the Hypertension 2017 guidelines? Well, we now recommend longer-acting thiazide-like diuretics, such as indapamide or chlorthalidone, over standard thiazides like hydrochlorothiazide. And importantly, we also recommend that single pill combinations be used as the first-line treatment. Single pill combinations are associated with better adherence, and not only that, they're associated with better blood pressure control, and beyond that are associated with better cardiovascular outcomes. So here is our new algorithm for the management of patients with hypertension broadly. We recommend, of course, initial treatment is health behavior management, diet, exercise, smoking, etc. And then you can choose from any of the available antihypertensive drugs that are listed here. Beta blockers shouldn't be used first line in patients over the age of 60, but you'll notice on the right side of the diagram that a single pill combination is recommended as initial therapy for patients with hypertension. So getting back to our chart audit, to our reflective learning exercise in the at-target program, we're going to broadly separate it into two groups of patients. Those who have already diagnosed with hypertension, and that applies to any of them pretty much. So any hypertensive patient is eligible to come into this trial if they're already being treated. But we are also looking for patients who you have not yet identified with hypertension. And those are patients who fit the Sprint criteria. So patients who are perhaps not treated but are over the age of 50 and have a recent systolic blood pressure reading of greater than 130 and less than 180 millimeters of mercury recorded in their chart. In addition, they of course have to fulfill the Sprint criteria, and that is clinical or subclinical cardiovascular disease excluding stroke, chronic kidney disease with an eGFR between 20 and 60, a 10-year cardiovascular Framingham risk exceeding 15%, or age greater than 75, but we don't want to include the patients with the exclusion criteria from Sprint, which is those with recent stroke, those with diabetes, those with symptomatic orthostatic hypertension, or proteinuria of greater than a gram a day. So on behalf of Hypertension Canada, once again, I want to thank you for your dedication to Canadians to achieve the blood pressure targets and thresholds that are recommended by Hypertension Canada in our guidelines. Thank you very much. Greater than